My name is Ollie Fine, and I want to welcome you tonight to this forum, which is sponsored by the New York Metro chapter of Physicians for a National Health Program. We're really delighted to see you all here to engage in this really, I think, interesting and important discussion. I wanted to make one or two announcements at the outset. One that you should know about is the development of the strike debt movement. I don't know if you've heard about this, but strike debt is a situation in which a group has gone ahead and at very discounted rates bought probably close to what? $1 million worth of medical debt, which they are now going to totally forgive as a way of illustrating, the ridiculousness of our healthcare system in terms of the kind of coverage that people have in the United States. This will be illustrated on Thursday afternoon at 4 o'clock, starting in Bryant Park. If any of you are interested, this group is going to be meeting and then making a little tour of our private health insurance industry, and you're welcome to join them between 4 and 7 p.m. starting in Bryant Park. Here in Union Square on Saturday, there will be a kind of health fair going. Pardon?
Washington Square Park.
Oh, Washington Square Park. Oh, they changed it. Okay, so it's going to be in Washington Square Park, where there will be a kind of health fair going on. Anyone who's a clinician that wants to volunteer to take blood pressures and that kind of thing is welcome to join us there. And then from there, that will be from 9:30 till about noon or 1 o'clock. Then in the afternoon, there are going to be a number of teach-ins around the city talking about medical debt. What causes it? How does it come about? And so forth. And then again, at the Judson Memorial Church, next to Washington Square Park, there will also be a health fair later in the afternoon. So tonight, we're really fortunate to have with us Dr. Matt Anderson. He is a graduate of Harvard Medical School who did his residency training in family medicine at the Montefiore program in the Bronx, joined the faculty there, is an active clinician, sees patients in a federally qualified health center in the Bronx, and is a teacher in the residency program for social medicine at the Montefiore Medical Center. In 2006, he, along with others, formed an online magazine called Social Medicine. He's one of the co-editors, and interestingly, this is a magazine that publishes all of its copy in both English and Spanish. Really fascinating project. And tonight, he's going to talk to us about how corporatization of medicine is changing clinical practice, a view from the front lines. Let's put our hands together and welcome Dr. Anderson.
Thank you, Ollie. So, I really can't thank Lori and PNHP, the executive committee, for inviting me to come talk today. I can't thank them enough. I feel a little bit like, I got called up from the minor leagues in the Bronx to come down and play in the majors here in Manhattan. So I'll try to be up to the task. I don't particularly like to use PowerPoint slides. And of course, to make me feel more comfortable, Katie reminded me that there have been studies showing that when you put bullet points up, people immediately stop. Their brains just stop totally. So I usually don't like to use it. There's a lot of sort of more visual material here that I'm going to show. And I also would like to get your response to some of the things that I'm going to show up on the screen. So let's see, this gets me forward. Hang on a second. I did this. Okay, so now the moment we talk about dealing with corporations, I think some of the rules that we normally assume about people that are giving us information, in other words, that they're giving us information because it's true, those rules disappear. And people are interested in hucksterism. And the first thing I'd like to do is sort of bring this home with an example of a book. Now, my hospital has only given me, in my entire some 20-odd years that I've been at Montefiore, 3 books. One of them was a book on HIV management, which we got, I think, sometime in the late 90s. Another one was the book I'm about to show you. And the third one was Jim Collins' Good to Great, which is a book that we could spend a lot of time talking about and analyzing. But I'm going to stick with the first book. Now, this was a book called Practicing Excellence, and it was published in 2004 by this fella, Stephen Beeson. And last year, my parents, or in 2010, my parents both passed away, and I spent a lot of time in hospitals. And I was struck by the fact that all of the hospitals were excellent hospitals. You know, in Montefiore, we have Montefiore excellence. You go to New York Hospital, you have New York Hospital excellence. You go to Columbia. I mean, everywhere you go, it's excellence. And what does excellence really mean? Why is this like this thing about excellence? So this was a book that this man wrote, this doctor wrote about practicing excellence. And I'd like to start off with something that he began at the very beginning of the book, which is sort of an example of excellence discourse. Changing a culture is about a willingness to commit to clinical and service excellence as a non-negotiable expectation of staff physicians, and to create physician buy-in so they lead this effort through example and influence on all who look to them for leadership. Now, what do we think about this idea? I'm asking, what do people think about this idea? Duh.
Well, it presumes the current culture is non-excellent. Right.
So it presumes the current culture is non-excellent. What other thoughts do people have about the idea that excellence is a non-negotiable demand of staff?
Well, it's pretty condescending to physicians and their role.
Condescending in what way?
Well, it's an expectation of staff. We've got to create buy-in, so they'll lead this effort. It's kind of like,
So this,
it's sort of the attitude of administrators towards clinicians.
right.
Suggests that staff want to negotiate on excellence.
Or even,
That would be the goal of staff.
yeah.
No compromise of medical principles, which we learned through the drive though.
All right, so this is kind of a very tough thing. This is coming from an authority figure. Any other thoughts about like the very concept of excellence being non-negotiable?
But it sort of assumes that people aren't trying.
Right, well, it assumes that people are kind of lazy and they need to be pushed. So I'm going to show you a little bit further on a book by a management consultant who criticizes management consultants. But he says one of the jobs of management consultants is to arrive in an organization and convince everybody that they're going to work a lot harder, and if they don't, they're going to get fired, which is sort of some of the subtext behind this. But how many of you have ever heard of Lake Wobegon? Yes. Now, do you remember how Garrison Keillor signs off each week on Lake Wobegon? What is Lake Wobegon? It's the land where, right, all the kids are above average, right? All the women are strong, the men are handsome, and all the children are above average. Now, you can't say that everyone's excellent. I mean, it kind of doesn't make sense, right? I mean, if you say that I'm going to run a high school and every kid in my high school is going to get an A+, someone's going to look at you and say, that really doesn't make very much sense. In other words, this sounds really tough, it sounds really strong, but like it doesn't make any sense, because if everyone's excellent, then everyone's normal, and there is no excellence.
What this requires is a corporate definition of excellence. So some standardized things, so there's a lot of health plans that are excellent by NCQA, but that standard is really low, relatively speaking. So what it implies is that someone knows what excellence is and can therefore enforce conformance to that standard.
Exactly. So this is somewhat of a lot of the corporate discourse that they know what excellence is and they're going to make you excellent. Now, just to show you how, like, this is really kind of a very silly book. Because when you read it, it's a whole book about how physicians ought to act. There's not a single footnote or citation in the entire book, but it does offer certain helpful advice. Well, yes. So here are a few key learning points on when you meet a new patient. A good first impression can create a captive, engaged encounter. A bad first impression is difficult to recover from. Knock, pause 2 seconds prior to entry. Now, I wonder, yes, number 5, of course, is the best one. But I look at number 4 and I wonder to myself, why do I have to wait 2 seconds? I mean, like, is there some study showing that waiting 2 seconds is better than waiting 3 seconds? And I have to say that I suspect the answer is what I was told in medicine, like when you prep a patient for surgery, you prep 3 times because 4 times is too much and 2 times is not enough. Okay, then you smile, shake hands, and introduce yourself to the patient, everyone in the room. You sit down and sustain eye contact. And then the most important one, in capital letters, look as though you enjoy what you do. Now, Beeson and his company were actually invited to come teach us excellence, a meeting that was mandatory, but which I will admit I did not attend. And I personally wanted to ask the people giving the seminar, when I am doing a breast exam, how should I look like I enjoy what I'm doing? Because I normally don't do that. The other situation that perplexed me is when I'm telling Mrs. Jones that she has a malignant breast tumor, how do I look like I enjoy what I'm doing now? In other words, this is really schlock. Pardon my expression. Now, I actually had the temerity to write to Mr. Beeson and ask him for a copy of his CV. Now, I mean, I'm not a great one that thinks that only professionals can give advice on something, but Mr. Beeson, other than having an MD, has no other degree, and to the extent that I could determine, he'd written only 1 peer-reviewed article ever, and that was on the auscultation, the use of auscultation of the chest for the diagnosis of PCP pneumonia. So it really takes a lot of chutzpah, and he didn't have extensive experience running healthcare systems, for somebody like this to stand up and tell me how I should run my practice. And I think this is an example of the sort of hucksterism that one finds rampant throughout corporate discourse. Now, if any of you are interested, oops, I jumped too far ahead. Let's see, how do I go back? Whoops, and now I'm jumping further ahead. I have to go back. So if any of you are actually interested, whoops, I want to get back from current slide, yeah. This is actually a wonderful and highly amusing critique of business management and the way business management has developed as a quasi-discipline, written by Matthew Stewart, who is a consultant. It's a very entertaining and a thoughtful book. So I think I was really invited here to talk about the death of the solo practitioner. And I just wonder, like, what associations do people in the room have with Marcus Welby? Like, he was, so Robert Preston, I want to say, Robert Young, who did this, came to this after doing Father Knows Best, which he did for a number of years. So Marcus Welby was clearly a very paternal figure. He played a paternal role. But what associations do people have with somebody like Marcus Welby? Is this a good model to have, a bad model to have? I don't really have an opinion about this one way or the other. I'd be more curious to hear how other people react to this image. Yes.
That he really cares about you.
He cared about you. This is a man who cares about you. Clearly that's a big part of the image of this man. What else?
Totally outdated.
Totally outdated. And you're talking about the kind of medicine he practices? Okay, so it's unscientific medicine or just...
Given the complex complexity of what goes on both on a clinical side as well as on the administrative side, it's impossible almost for any practitioner to keep up with what's going on and to administer it to the patient or she sees.
So
It's usually the implication that medicine was better when these type of doctors were there. You also often hear, oh, the age of Marcus Welby is dead, and we have different things which somehow or other the golden age is past, and now we just have all sorts of terrible things.
I always thought when I saw it back in the 70s that it was kind of hokey and schlocky, and it was this romantic image of small town America, which wasn't part of my reality at all.
there were other.
All that's true, except that there was a doctor-patient relationship, there was continuity of care, and he didn't just look like he enjoyed what he was doing.
None of that exists today?
I didn't say that, I
And you,
just
and
said
you
that's
felt
what.
like you could trust him, and I mean, I'm older than Mark, but not that much, but my father was a Marcus Welby-like person. My father was a general practitioner in Brooklyn. He had his patients for tons of years. He was, by himself in his office, and when he got, after a while, patients used to go to specialists. He called them professors. He was always called them professors. And then they'd come back to him and say, he wants to do this, they want to do this, they want to do that, should I do it? And they trusted him. I mean, I don't think it was all bad.
I don't think anyone thinks it's all bad. Yeah.
Yeah, it's interesting. There are two books, Overdosed America by John Abramson and White House, The Myth of Alzheimer's, in which they call for going back to the very highly personable relationship and more of a diagnosis with the interview, with the less emphasis on all this high-tech equipment.
Okay.
So it's interesting to look at those two texts.
A knowledgeable, very knowledgeable doctor also knew how to reassure the patient and create a sense of stability and reassurance.
Other.
I certainly would like to practice like that. No, seriously, that's my model.
So what does that mean for you? What would that mean?
Well, again, somebody mentioned the continuity of care, the idea of the relationship with the patient. Those are all good things.
Okay. Other.
Computer, he's talking on the phone.
Go ahead. Any other thoughts? Go ahead. There's both of you. Then why don't you go first?
After all, I'm 86, and I remember when I came to your home and knew the family, knew the setting that you were living in and what your situation was, and all of those aspects that I think are part of healthcare. They're not everything. I believe in group, because I think the synergy of many people working together is an important part of healthcare also. But I was just saying that there were aspects of coming to the home or knowing the whole family and being in a community. Those aspects are important too, because they change how the doctor might think about the patients when they understand better.
Okay.
Just seeing a difference between, like, I've never seen this television show before. It sounds like but,
Well, just look at them. I mean, they're black and white.
But there's a difference between, like, from my own experience working as, being in nursing school and also just attending doctors myself, doctors that are just, that really will listen and actually, like, listen to what the patient is saying and take that into consideration, whereas, like, there have also been some doctors that just go by the written diagnosis in the chart and will start prescribing stuff out of what sounds like thin air and without actually listening to what the patient is saying or listen to what other people are saying. And that's where I feel a lot more harm gets done more than good.
All right. Let's take one more comment.
It makes me think of those reactionary sort of paternalistic AMA ads. You look at them and it's the nice doctor always telling people why they shouldn't get involved with politics, and the doctor should, they know what's right, trust your doctor, kill whatever.
whatever reform health bill is being offered at the time.
So that's certainly one thing. One would associate, like Ronald Reagan talking about socialism was coming with Medicare. All right.
was very much involved in the production of the show.
All right. So I suspect I was asked to give this talk because of this article, which was from 2010 in the New York Times, about how doctors were selling up their private practices to hospitals. And this article, someone's shaking their head. Was that what the executive board had in mind? So this article, which I won't go into the details, had this particular graph in it. It was actually on the side, which showed the percentage of medical practices owned by doctors and the percentage of medical practices owned by hospitals. And you can see a dramatic change really on this graph between 2005 to 2008, where all of a sudden the number of practices owned by doctors dramatically sinks and the numbers owned by hospital dramatically increases. And this was extensively commented on and sort of got into the sort of idea that private practices were being sold to hospitals. Now, so again, along the lines of never believe anything a businessman tells you, I went and actually looked up data from the CDC. Now, the CDC does a very scientific survey of all primary care visits. This is a sample. You can go and there's pages and pages of documentation about how they came up with what's supposed to be a nationally representative sample. But you can see that over the period when that big drop was supposedly occurring, I'll just notice that the number of solo practice visits, now these are patient visits to doctors, went from 39% of the total visits to 32% of the total visits. And in terms of practice ownerships, physician or group physician practices, which were 87%, I don't know if maybe I should come up here just to make sure. So here's data from 2005 when there were 963,000 primary care visits, or ambulatory visits in the United States. Of those visits, 39% were with solo practitioners, which is pretty amazing. And if we add in people who work with their partners, it's just about half, about half the visits. Even more than half the visits are still occurring in practices of 1 and 2 physicians. Yeah?
Well, I just want to thank you for putting those two together because it just solved it. What happens is the hospitals are buying specialty practices. And so the number of visits is not changing much, but the cash flow is because the hospitals are charging for the facility fee for outpatient specialty procedures. And that's what's driving this.
Okay, but it's important, I think it's important because there is, what I would like to argue is there's this whole idea that private practice is dead, no one wants to do private practice, the solo practitioner is dead, this is all antiquated medicine. But in fact, the numbers really show that from 2005 to 2009, so this is the period of the great decline that we just saw, actually primary care visits are still 44% of the total. Now, we can see a decline here, but it's nothing like the dramatic decline that is described in the New York Times article. And again, in terms of practice ownerships, it was still true that 87%, now remember this is of visits, occurred in physician or group practices at the beginning and 82%. So there is a decrease, but if we go back and look at the slide from the New York Times, which I hope I can go backwards. Does anyone know how I can go backwards on this? The up arrow? Yeah, I mean, look at the dramatic change here from 70% doctor-owned to less than 50%. Now, if you think about it, actually, this slide really doesn't make very much sense because that kind of a dramatic change in the structure of the U.S. healthcare wouldn't have occurred over a period of 3 or 4 years. Yes. Now, okay. Well, so very good. So here again, you've got to write to Dr. Beeson and ask him for his CV. And the source of this, I don't think I have that slide. The source of this is this Medical Group Management Association, which is a private company that provides consulting services. And they do a survey, which any of you are free to go online and fill out their survey about your particular facility, and that's the data set upon which they work. So this is nothing near the scientific rigor of what the CDC is doing. And yet, this story was picked up and transmitted and had a lot of comment, and nobody really thought to go back to question whether or not this data was right. And again, I think it's all part of this ideology that solo practice and private practice are dead, when that really doesn't seem to be the case. So there are threats to private practice and solo physicians, and I'll just go over some of them. Certainly, this is, I think, the slide where Katie would tell me they're all asleep now. So certainly the regulatory burdens and the costs of EMR are quite high, and anyone that's had to work with these knows what I'm talking about. There's certainly a lot of economic uncertainty. You know, every year there's these draconian cuts in the reimbursement rates for primary care that keep getting postponed. There's certainly safety in numbers, and that's true both because in big numbers you have a monopoly, and you know there's a reason why Montefiore owns almost all the major health facilities in the Bronx, because I'm sure it allows them to negotiate much better rates. Plus, if you want to have an accountable care organization, you want a big organization because it spreads your risk. One of the things I think you were referring to this is once a private practice is sold to a hospital, they can start charging a lot more money for the same procedures because they're part of a hospital. And finally, it's certainly true that for doctors, and we know that increasingly the workforce, the physician workforce is female, being an employee offers better lifestyles and presumably less administrative work. Now, I want to turn to what I think is sort of the ideology that I hear now, which is telling me the private practitioner doesn't work, you've got to work as part now of a team. Am I going backwards? Oh my goodness, now I'm going really backwards. Okay, so this was actually an article published in the Annals, recently in the Annals of Family Medicine, which really sort of tries to give us why we shouldn't want to be Marcus Welby's. So it says, cultural values and beliefs about the primary care physician bolster the myth of the lone physician, a competent professional who is esteemed by colleagues and patients for his or her willingness to sacrifice self, accept complete responsibility for care, maintain continuity and accessibility, and assume the role of lone decision maker in clinical care. Now that's one way of describing a solo practice. They've chosen their terms with certain particular purposes in mind. Yet the reality of current primary care models is often fragmented, impersonal care for patients, and isolation and burnout for many primary care physicians. An alternative to the mythological lone physician, I see him up on Olympus, would require a paradigm shift that places the primary care physician within the context of a highly functioning healthcare system. Now that, I think, is the myth right there. The fact that we have anything like a highly functioning healthcare system. This new mythology, and I'm struck by the fact that they call this a mythology, better fulfills the collaborative, interprofessional, patient-centered needs of new models of care and might help to ensure that the work of primary care physicians remains compassionate, gratifying, and meaningful. So how do people respond to the ideas? What do we think of these ideas? Do I hear someone say bullshit? Yes. Why would you say bullshit?
Because I work in a health center that is chaos. With teams. And it's not highly functioning. And I have so much paperwork to do, it's insane.
I recently retired. Until 1 or 2 years ago, I felt that I was the center for the patient that would arrange all the consultations, working together, interacting with the other doctors, and then when the patient asked for a final opinion, I would then give it to the patient. It was totally inclusive, and it was a wonderful way to work. But in the past year, I had enough of it and I quit. But that's the way I worked for 35 out of 40 years, without any problems, using all the physicians when I felt there was a necessity to call in a specialist, I would call in a specialist. If the patient didn't like him or her, I would call another. But we worked together. We called each other. Nobody calls each other anymore. And we discussed the case, and then the patient made the final decision based on our input. It worked very well.
Other thoughts?
I worked for many years in a rural setting with a lot of solo practitioners all around. And some of the care there, I think, was just terrible. I have a very satisfying practice, but I think the notion of any one individual having the sense that they know what the reality and all of the different permutations of medicine are is a challenging one. And I think that's part of the balance here of how does one maintain that sort of fundamental doctor-patient relationship at the same time that one understands that one individual may not have perfect knowledge.
Okay, so you're sort of going off the idea that things are very complicated. They're certainly more complicated now than they were before. Didn't Osler say there were 5 medicines that worked? And now, God only, there's 5 million medicines.
And that we're all average, and that we make mistakes, and so to do this in isolation is a problem.
Okay, other thoughts?
I work in a public and a private hospital at different times, and this team-centered model cannot work when usually the first question I'm asked is, what type of insurance does this patient have? So, I mean, right there, that just destroys this whole patient-centered idea, because it's not about the patient, it's about can they afford it, and that just usually is a roadblock most of the times in care. So.
Throughout my practice, I've always worked in the public setting in my private office, and when that question about insurance came up, I could refer to the public sector because there are more services available than in my private office. But what's happened in both the public sector and in the private sector, I see a couple of doctors from Doctors Council here, that as the older doctors are dying out or retiring, that collaborative relationship that doctor had has disappeared, both in private and public. And that question about insurance becomes even more paramount. You know, I had a patient in the private sector who had what may have been tuberculosis, but because the person was in for a vascular procedure, and there was a question about tuberculosis, but the pulmonary consult who came in did not take the person's private insurance, so he just sent him home. And that happens over and over again.
All right. Yeah.
What I think of when you say solo practitioner is the fact that when we took care of patients, they were my patients, meaning that I was their solo practitioner in the sense that I had to follow through on all their care, on all their lab results, on all their and continued care. I mean, we worked collaboratively because, you know, we had input from other people, but we were the primary person responsible. And that makes it seem like, Jesus, you couldn't go to sleep at night if you would, you know, but I mean, it was doable. You know, you could, there was nothing wrong with following through on patient care and being the solo practitioner. You were the person that knew the patient, you know, I mean, how many errors are committed because you don't know the patient, you know?
All right. Other thoughts on?
There's been nothing here about time in any of these quotes that you've referred to. So there's been nothing that talks about time and the time involved in terms of being able to practice like this. And there's also been nothing there's a little bit talking about collaborative, but nothing talking about sharing, which was what I was hearing before in terms of you shared the information with a colleague or you called another doctor when you had a question or such, which again relates to time.
All right. Well, now presumably one of the ideas of the new methodology of team-based care is that the doctor then can devote more time to doctoring activities, and other people would have the time to do activities that doctors often do but were less doctor-like, like calling prescriptions or I don't know, arranging follow-up appointments. Yes.
I was at Montefiore Hospital when the AIDS was just starting, and nobody knew what it was. And
Oh.
we had a team of the team was headed by 2 doctors, but there was it was never a head anything because we were a team of nurses. I'm a social worker. There were even a dentist because all of the multiple illnesses they had. And we went and saw every patient in 2 hospitals, Montefiore and North Central Bronx. And there was a sense of it being only, getting to know patients. When I started a group, the 2 doctors said, well, we'll come because you don't know anything about the illness or anything, so we'll take turns. After a couple days with a group of 22 patients who were young and dying one after the other, they learned so much they couldn't stay away. The doctors went and got the patients and brought them to the group because they learned more about how to help. Both of those doctors are still around and doing lots of things.
All right. So I'm sort of getting a sense, just if I could, that both of these things, both being a solo practitioner, working in teams, have advantages and have different kinds of advantages. I somehow still feel that someone's trying to sell me something when I read this. That it's a little bit like Mr. Beeson telling me that I have to look like I enjoy what I'm doing. You know the problem? Yes. Somehow I'm pressing the wrong button at the wrong time. All right. So I feel like a lot of what's going on, particularly with the idea that solo practice is dead and that we have to work in structured teams, is because corporations want to control what we do. And this is what I will spend a little bit of time talking about now. And specifically about partnering with corporations. Now, doctors are really, healthcare is what percentage of the 17%. And we're a tiny, tiny, tiny part of that. But we're an important part because we write the prescriptions and we sign off on the home care things, so that we're like the grease that makes the system work. So the corporations have got to make sure that the grease is doing what the grease is supposed to do. And that's why I think they're very interested in micromanaging what we do. And so I'm going to spend the next section just sort of talking about some of the various corporate partnerships with corporations. So this is the Patient-Centered Primary Care Collaborative, which was set up by IBM because IBM felt that it could get better health out of its workers by giving them primary care. So, and they realized that the whole system we had was structured around specialists, which they thought didn't make sense. Of course, they're right about that. So they got very interested in the patient-centered medical home, and they set up this collaborative. And I don't know if this slide is going to kill you. Hopefully it won't. These are the 56 members of the executive committee of the Patient-Centered Medical Home Collaborative. So let's just go over. We've got, Aetna here, we've got Lilly, we've got Pfizer, we've got Humana, we've got all the big corporations. This is almost like the blue chips of the medical industrial complex. And then we have the American Academy of Family Medicine. We've got the American, the pediatricians. And so, I think if you go to sleep with sharks, you shouldn't be surprised if you wake up and you're missing a limb. And I'm going to talk about this now. So the first thing I want to show you here, this is from, if you go on the Babies R Us, the Toys R Us website. This is a kind of like a pamphlet that got into our clinic. Now, we're not supposed to have any pharmaceutical reps in our clinic. We're not supposed to have anything that's from the pharmaceutical company. And I swear to God, they're like cockroaches. You walk into the clinic and there's all this stuff from pharmaceutical companies, these glitzy magazines, advertising stuff that we're telling people not to use. Right? Like, I'm busy telling my patients that they shouldn't be drinking juices or going to McDonald's. And in fact, The guy who used to run the lactation program at our clinic, it was his job to promote breast milk. I said to him, he called me up, I said, Scott, do you know there's advertising for baby formula in your office? He said, no way. I said, Scott, take your right hand and reach over to the filing cabinet. Pick up what's on top of the filing cabinet. And it was one of these pharmaceutical ads for new mothers with advertising for baby milk. Now, to put a little context on this, most of the clinicians here will know that there's no reason you would ever not want to breastfeed your baby if you could. And pretty much everybody can. And the WHO signed an international convention. They wrote it up. All these companies signed on, saying that it was illegal to advertise breast milk substitutes to the general public. So it is illegal. There's a boycott against Nestle all over the world because Nestle does it against the law. Guess the country that doesn't have a law against breast milk advertising? It's the United States. And in fact, not only is it legal here, but I'm going to say a bad word. The American Academy of Pediatrics puts its good name on advertising for breast milk substitutes. Now, the first question is, this is basically like an infomercial for new mothers with all the things they need to do to prepare for the baby. Now, in the United States consumer culture, getting ready for the baby means you buy things, right? That's how you get ready for the baby to come. And this is full of all the things you're going to buy. The American Academy not only puts its imprimatur here, of the American Academy of Pediatrics, right there, but it says that the content of this resource guide has been reviewed for consistency with the health and safety recommendations of the American Academy of Pediatrics. So they endorse this stuff, and just in case we want to have the right hand wash the left hand because we are in the world of corporate, they then give a little they give a little shout out to the book that AAP, these two authors who did the review, they wrote for mothers. So, and you can buy that at Stores R Us. So the right hand washes the left hand. And this particular image, I put it because of that, but in fact, there you go. You see all the ads for Enfamil, Similac, all of which would be illegal in other countries. Now, not only does the American Academy of Pediatrics put its name to this stuff, but in fact, Abbott Laboratories, the people who make Enfamil, sponsor all of the CME that the American Academy of Pediatrics does, which means that residents and attendings every month, they get their little copy of Pediatrics in Review, and there's the Abbott logo on it. So it is totally, totally normalized that women would be using breast milk substitutes. And the American Academy of Pediatrics knows better, because their own statement on the thing says that this shouldn't happen. And I actually gave the first version of this talk in Ankara, Turkey, and I went to the museum in Ankara, Turkey. And this is one of the oldest pieces found on an archaeological dig in Ankara, which of course is a mother breastfeeding her baby. I mean, this is like so fundamentally human an activity that goes back, millions of years. And, the breast milk industry is managing to get rid of it. They've isolated. I mean, how many patients, all of us who take care of kids and pregnant mothers know that all these women are coming to us and saying, I can't breastfeed, I'm not producing enough milk, because that knowledge has been beaten out of them by people like the American Academy of Pediatrics. Now, I can't speak bad about the American Academy of Pediatrics. This is entertaining, yes? Good, okay, good. Without mentioning my own specialty, which is family medicine. Now here is familydoctor.org, and this was just happened before I went to Ankara. This was up on their website. It says, worried about putting on a little weight during pregnancy, this is not the time to diet. Instead, concentrate on eating healthy foods and avoiding the empty calories and junk food. The typical pablum that you would expect to find on a website. Okay. Now, what I would draw your attention to here is this little button up here that says Live Positively, which when I first thought, I thought, oh, it's for an HIV drug, right? Does anybody know? Yeah, I know there's hands shaking around. Does anybody know what Live Positively is?
Coca-Cola.
Coca-Cola, right. So this is going to take us to a Coke ad sitting right next to another useless vaccine, a vitamin company. So I must say, you really feel like somebody really wants to screw the American mind over. Because on the one hand, you have this little thing talking about avoiding junk food. And on the other hand, FamilyDoctor.org is a proud partner of Coca-Cola. Now, I mean, I don't know. You really have to like totally, I don't know what you have to do to make people's minds hold those two ideas together at the same time. I'm going to skip over that. Now, if you actually go to this page, which is about sugar substitutes and what you need to know, this is the page where the ad shows up for Sprite Zero. And I mean, I just don't know how it's. Yes, because what you didn't know was that
aspartame was good for me.
Is that you can actually fight cancer by buying Sprite Zero and presumably drinking it too. And that is the imprimatur of the American Cancer Society. Yes, exactly. It's right on the can.
What's the story?
I think they're going to donate maybe a penny for each can you drink to the American Cancer Society. Yeah, but what's the story? Yeah, well, we know what the story is. Buyer beware. So this is really disgraceful. And just in case you thought that our public authorities were going to save us, oops, oh, now I'm going to jump down a whole page. Well, let's see what I do. Okay, I'll have to go back here. Bum, 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 bum. Just to remind you, because there'll be a quiz afterwards. Here's this National Heart, Lung, and Blood Institute. Proudly co-sponsored with Diet Coke. Okay, they've actually changed now. They're sponsoring with Diet Pepsi. But
well, that's okay.
you know, is it really the job of the National Institute of Health to put this on their website? And what on earth are they telling the citizens of the United States? So this is why I think it's dangerous to partner with corporations, because of course they have so much power and they have so much money, and they're going to get what they want. So I want to come and talk a little bit about like how one feels this in the clinic, and this relates to the idea that somebody knows what excellence is. Well, one of the big corporate pushes is what's called, well, I wrote $P$P, but this is really P4P, which is pay for performance. And this is the idea that you're going to pay doctors to hit certain specified clinical targets. So, for example, you will get more money if a certain percentage of your patients have their diabetes controlled to a certain level, and more money even if they get it to a lower level. And these programs are being rolled out. They're kind of the centerpiece of this kind of, we're going to get tough, we're going to motivate the doctors to do the right thing. And Steffi and David wrote a wonderful critique of sort of the psychology of this that was published. They probably came and spoke here about it, yes? And about the fact that actually giving money often demotivates people. But I really want to, this is kind of this corporate tough, we're getting results. If you don't give us results, you don't get paid. Now, the fascinating thing, and I'm just going to take this one example because I can't talk about all of them, is there's really not any evidence that this improves clinical outcomes. All right? And that's just like so important, because if you're in business, you can sell anybody anything, but we're not in business, we're doctors. And one of the things that makes me, I have a lot of problems, I'm conflicted about academic medicine, but I do think that one of the things I like about medicine is we at least strive to make sure that what we do is based on evidence. It's not just based on expert authority or somebody's good idea or an anecdote that we heard. And that's our better side. So why we are supporting pay for performance when there's no data that it works is astounding. And this is through the board. We wouldn't take, and the patient-centered medical home is another example. AHRQ just came out with a review saying there's really no data to show that the patient-centered medical home improves outcomes. There's data to show that specific elements of it might improve outcomes, but as a concept, this was bought and sold to us. It was told us we were going to have to do this without any evidence. We just wouldn't do this for medications. We wouldn't prescribe a new medication unless there was evidence for it, and here we are doing something that's not evidence-driven, which again, it's the hucksterism of corporations. The goals don't make much clinical sense, at least not to me. Now, we want to lower people's sugar when they have diabetes. How low is low? What's the right number? We don't know. And I don't think there's anybody here that can tell me that they know what the ideal number that we should be reducing their sugar by to is. Kate, you can take that out when you do edit that out. But even more to the point, there's a big difference between somebody who lowers their sugar because they walked and they lost weight, and somebody who lowers their sugar because they took metformin, which probably does them a lot of good, and somebody who lowered their sugar by any one of these new drugs, which we really don't know a lot about what they do other than the fact that they lower sugar. And as we know in medicine, improving the numbers can often make things worse. So that we're really we're really sort of uncharted waters here, and I think the goals just don't make sense, and I think the idea that somebody really knows what clinical excellence is really highly problematic. Which doesn't mean that it's good to have bad doctors, that everybody can do what they want, but this doesn't seem to me like the best way to do it. Now, it's practically very difficult to do this, because if you work in a big system, particularly if you work in a team, who's really responsible for a patient? 2 years ago, I went to the American Medical Informatics Association meeting, and I sat down for 3 hours and listened to the folks from the Mayo Clinic talk about how they couldn't figure out who the PCP was because people have been seen by so many doctors. So finally they said, well, we just put down the PCP as whoever the insurance company said the PCP was. Well, everybody here knows why that's like a totally crazy thing to do. But they couldn't figure out a way to assign an outcome to a particular doctor because patients had so many different doctors. And then the other thing is the doctor really so powerful? I mean, the whole assumption here is that, getting Mrs. Diaz's sugar down is something doable, and if I just worked harder at it, I could get Mrs. Diaz's sugar down. And I really wish the person who wrote the guidelines would come and sit with me when I'm with Mrs. Diaz and help me to do it. I mean, I don't think that I could be doing much more, and then I often feel like I'm beating my patients to do things that are essentially impossible for them to do, and it's really not very nice on my part. We know, for example, that dietary counseling does really no good, and yet, we're, anyway, you hear my pain. Also, does this really measure what a primary care doctor does? And I think this is where we come back to the Marcus Welby part of it. Now here, I'm going to tell you an anecdote. One of the best things I ever did was as a doctor. 8:30, okay. I don't want to go too much later. So I had a patient, a woman that I took care of. She'd had schizophrenia throughout her life, and she'd gotten a lot of antipsychotics. And when I met her, she was in her 70s, and she didn't like to leave the house, and I was willing to go do home visits for her, so I went and visited her in the home maybe every 6 months, because she was pretty stable. And either because of her mental illness or because of all the antipsychotics she got, she really couldn't talk or explain herself very much to me. But I worked with her daughters. She got admitted to the hospital a couple of times because she had diabetes and gastroparesis. And we had all agreed that should she ever have, we talked about getting a mammogram, we all agreed that if she ever did have a cancer that we wouldn't do anything about it because she just didn't like to leave the house. So the family called me over one year. They said, Mom has a really bad cold. We'd like for you to come and make sure she doesn't have pneumonia. So I went over to the house and I looked and I examined her and said, oh, she has a cold, don't worry about it. And then the daughter said, well, she has this thing under her breast. So I reached down, and she had this hard mass under her breast. She had a cancer, clearly. And I said, well, she has cancer. What are we going to do about it? and the daughter said, well, we want her to die at home. So I called up my friend in the palliative care program, and I said, well, I'd like to put her in the palliative care program. Do I need to do anything? And she said, all you need to do is write a letter saying that she's going to be dead within 6 months, and we can get her palliative care. So I did, and the palliative care team arrived, and they were really wonderful. And 6 months later, I was I was at an air show with my kids, and they called me up and they said, you know, Mom's really breathing hard. We think she's going to die. The whole family was there. And I said, okay, we'll just be with her and hold her hand. And then they called me up a couple hours later, and she died. And to me, this was like the very, very best thing I did the whole year, because she died at home. She died with her family. There wasn't a single blood draw. There wasn't a single biopsy. Nothing happened. And this is what everyone wanted to see happen. Now, I kind of think that the reason that this was at least in my mind, this was successful was because I had a very personal relationship with the family. They had a very personal relationship with me. We knew each other. We trusted each other. And that's a dimension of what primary care is, that the numbers about blood pressure and pneumovax and hemoglobin A1Cs can't even begin to touch. And that's very important. I mean, I really think that's central to what we do. That's what we can do as primary care doctors. And so finally, the other thing is, does pay for performance undermine the core values of primary care? And I say this because, a patient came to me and said to me, Doc, should I get a flu shot? And I said, this was a patient I'd been with for some time who kind of didn't like doctors. And I said, yeah, Mr. Douglas, I think you should get a flu shot. I got a flu shot, and I think it's the right thing for you, which I did. Now, then I have to think, well, if I'm getting paid every time a patient gets a flu shot, and that's supposed to motivate me to give more patients flu shots, and someone comes and says, Doc, do you think I get a flu shot? And I now turn to him and say, well, I think you should get a flu shot, but you should be aware of the fact that if you get a flu shot, I'm getting $5 more. I think this would destroy what that person is coming to me and seeking. It's totally the opposite of what they want from me. And there are two ideas that I have found very useful in thinking about these. I want to share them with you because they're really critiques of this. This is all an example of using quantitative numbers to measure things in a way that's totally inappropriate. Now, the first law, this was enunciated by an American sociologist, it's called Campbell's Law, and it says, the more any quantitative social indicator is used for social decision making, the more subject it will be to corruption pressures, and the more apt it will be to distort and corrupt the social processes it is intended to monitor. Now, that's a very complicated sentence. I think I can give you an example of this. This is used to critique high-stakes educational testing in school. In other words, if the fourth grade teacher knows that his job as a teacher, and the principal knows that his job as a teacher depends upon the kids getting good grades on the fourth year tests, they're going to make goddamn sure that those kids get good grades. And they're going to teach to the test, and the ultimate quality of the education is going to decline. I mean, I've seen this. It also makes kids fat, too, in case nobody had noticed. Because the only time they don't get any more schooling. So this is also true in medicine. I mean, if you tell the head of the ER, look, your job depends upon your having patients seen within 20 minutes, I am sure that the director of the emergency room will now devote a massive quantity of effort and resources into making sure that something happens within that 20-minute period that makes it look like patients are being seen, even though they're not, because it doesn't really address the problem. So this is one of the problems with high-stakes quantitative measures, is they get corrupted. And when they get corrupted, they make things worse. In fact, I went to the Toyota dealership, and they had one of these high-stakes things. The guy said, oh, well, we want you to rate our service. And you should know that Johnny, if he gets a bad rating, that's really bad for him. Okay, well, I'm not going to give Johnny a bad rating. And I'm sure everybody in this room has experienced something like that. The other thing, and this more relates to what it is we're measuring, is McNamara's fallacy. Now, the reason this is called McNamara's fallacy is McNamara was really a numbers guy. McNamara was a systems thinker. He was really into quantitative measures. That's why he was hired to run the Pentagon, and this is what he brought to the Vietnam War. the body counts. And I don't know, I can certainly remember as a kid growing up, and every night Walter Cronkite would get up, and it was a little bit like the baseball scores. You know, there were so many U.S. soldiers killed, so many Republic of South Vietnamese soldiers killed, so many Viet Cong killed. And this was like how you were going to win the war. And McNamara has said it. You know, he wanted to kill a certain number that they'd figured out of Vietnamese, and that would cause the Vietnamese to surrender. So this was dubbed in the business literature, and this is actually from some of the critical business literature. The first step is to measure whatever can be easily measured. This is okay as far as it goes. The second step is to disregard that which can't be easily measured, or to give it an arbitrary quantitative value. These are like, you know, do you like your doctor? Do you like your doctor a lot? Do you like Dr. Little? This is artificial and misleading. The third step is to presume that what can't be measured easily really isn't important. This is blindness. And the fourth step is to say that what can't be easily measured really doesn't exist, and that's suicide. And I would like you to keep this in mind, because there are some things you can measure and some things you can't measure, and sometimes the things you can't measure are very, very, very important. Now, I'll tell you something you can't measure, but I'll give you an example. You know, for various reasons which I don't understand, the hospital has decided that getting good patient satisfaction scores on Press Ganey is extremely important. And they devote enormous amounts of effort into getting good Press Ganey scores. Now, Press Ganey are patient satisfaction scores. Now, again, we're in corporate la-la land here. So how do you go about getting good Press Ganey scores? Well, it turns out that Press Ganey not only administers the surveys, but it also advises you on how to get good scores. Now, if that isn't a total conflict of interest, I don't know what is, but that's how things work. This is more hucksterism. Okay. I'm going, I think, since I'm going, there are, so as more doctors become employees, I think the issues of really, this is from something that the AMA wrote in December of 2012. I can't believe I'm actually quoting the AMA. But it says, and I think this is what we all feel about Marcus Welby, that kind of image, a physician's paramount responsibility is to his or her patients. And I think this is where we get into problems when corporations are trying to run things. Additionally, given that an employed physician occupies a position of significant trust, he or she owes a duty of loyalty to his or her employer. This divided loyalty can create conflicts of interest, such as financial incentives to over or undertreat patients, which employed physicians should strive to recognize and address. So these are some of the contradictions, and I want to talk, I think my time is getting short, so I'm just going to briefly touch upon, you know, I think a lot of people are walking out of the door on this system. You know, people form free clinics, and there was a survey done actually, there are over 1,000 free clinics in the United States that provide 3.5 million visits. Linda, you have a free clinic, don't you? Yeah, and there's one that students are doing the free clinics. There are a lot of people exploring alternative practice models, such as co-ops, concierge practices, and micro practices. And then there's doctors' unions, although the whole legal climate towards unions is really very unfavorable right now. So I mentioned that the first version of this talk I gave in Ankara. And one of the things I found was that the Turkish Medical Association, every slide they got up, they showed a picture of Karl Marx and then talked about Marx. Now, I couldn't really understand any of it because the translation was so bad, but they felt very comfortable talking about Marx. So I'm actually going to talk about Marx right now. And I'm going to talk about Marx and money, and I'm going to talk about the different ways money is used, and I'll try to be quick. So this is the way we normal human beings think about money, which is that we make things, we exchange them for money, like we sell things, you know, and then we use that money to buy other commodities, okay? And then we use these commodities. So this is like, we're doctors, we sell our work as doctors, and then we buy whatever it is we buy, okay? And this is a kind of exchange that's existed for a long time in human history, and we know that
in this particular type of exchange, the product that you make is really important. In fact, we know that a lot of names comes from products. I mean, that's why we have Smiths and Taylors and Weavers, because people were so closely identified with their product, the thing that they made, or bakers. So you start out with the commodity you make, and you end up with another commodity. And this is pretty limited because any human being can only make so many commodities or consume so many commodities. This, however, is the general formula for capital, where you start out with more money, you buy commodities, and you start out with a certain amount of money, you buy a commodity, and you end up with more money. Now, in this particular line of business, the commodity is essentially irrelevant. And GE is a good example of this. GE makes fighter jet planes, it makes things that are highly polluting, and it does stuff in the healthcare industry. But the more important thing, so this is totally irrelevant. The product you make is essentially, and you could even make something that's bad. I mean, tobacco companies make something that kills off their clients, right? And a lot of the iatrogenesis in medicine probably is bad for the patient. But when you end up with what you had before, but you just have more of it. So that there's no particular end to this cycle. In fact, John D. Rockefeller said it best. Someone said to John D. Rockefeller, when is a rich man happy? And John D. Rockefeller said, when he has a little more, right? But there's never enough. This cycle can never, ever, ever end, because that's why the capitalist system must continue to grow all the time. Now, the reason I mention this is that a lot of the things that we saw don't make any sense if we think that the world is run like this, but they make a lot of sense if we think that the world is run like this. And I know that a lot of people feel that, well, we have to get the economy under control, and we have to start producing things that people can use and need, and make production be about satisfying human needs. But right now, this is not about satisfying human needs. Satisfying human needs is only an incidental byproduct of this particular thing. And it's really hard, I think, to see how one can control this process so that it really produces things that are actually of use to people. That's a big problem, and just saying let's do this isn't the way to get there. Okay, that's, I think, what I have to say.